You know, usually when we talk about taking an exam or facing any kind of professional assessment, there's this underlying expectation of speed. Like you're trained to beat the clock.
Right, yeah. You rush through multiple choice questions, you scramble to finish the practical portions.
Exactly. And the general consensus is just that, well, the faster you operate, the more competent you are.
Which is, I mean, we're deeply conditioned to view speed as the ultimate metric of mastery.
Right.
If you can do it quickly, you must know what you're doing.
But, when you step into the world of professional caregiving, that entire mindset just has to be totally dismantled. We're looking at a landscape today where rushing isn't just frowned upon, it's the specific mechanism that will cause you to fail.
Yeah, it's the very definition of a high-stakes environment where slowing down is, it's really your only viable path to success.
Right. So, welcome to the deep dive. Today we are unpacking the TESDA Caregiving NC II Comprehensive Assessment Manual, specifically the 2026 edition.
It's a heavy manual.
It really is. And for those of you who might not be familiar, this is the definitive preparation guide for candidates entering the caregiving profession. We've got a vast territory to cover today, from professional ethics and taking vital signs to emergency protocols and daily patient hygiene.
Yeah, and reading between the lines of this manual reveals, well, so much more than a simple how-to guide.
Definitely. Our mission today is to look past those technical checklists and discover the profound science, the strict ethical boundaries, and the physical mechanics required to just keep another human being safe and dignified.
It really acts as a blueprint for preserving human dignity when people are at their absolute most vulnerable.
Okay, so let's unpack this. In the manual's own pro tips for assessment day, the authors explicitly note that the majority of candidates fail not from a lack of knowledge, but because they rush.
Yeah, they let the anxiety of the test push them to skip critical foundational steps.
Right. The text literally advises candidates to breathe. It states that a calm, deliberate pace is what actually signals competence to an assessor.
Which makes perfect sense. Caregiving is all about establishing trust.
Exactly.
And you cannot build trust with someone if you look like you're rushing to be somewhere else.
So for this deep dive, we're going to match that ideal caregiver's energy. We are aiming for a reasonable, normal, deliberate Filipino pace. We are going to take our time.
I love that.
No rapid-fire jargon, no rushing to the finish line. We want you, the listener, to have the space to really, truly absorb these concepts.
I really appreciate that approach, especially because this manual introduces a concept called automatic non-competency triggers.
Oh, right. The instant fail.
Exactly. These are instant fail scenarios.
Yeah.
If you make a single critical error, like leaving a client unattended in an unsafe situation, or using incorrect body mechanics during a transfer.
Or compromising hygiene protocols.
Yes. The assessor stops the exam immediately. The stakes are just so high that every single physical movement must be intentional.
Intentional. I like that word. And before we even get to those physical movements, the lifting, the medical metrics, we have to look at the psychological foundation.
The ethics.
Right. The manual makes it very clear that without ethics, the technical skills mean absolutely nothing. The primary goal is maintaining the client's dignity and independence.
And the manual anchors this in a few core values.
Yeah.
Take respect, for instance.
Okay.
It defines respect in a way that requires just immense professional discipline. Like, you're required to honor a client's right to make decisions about their own care, even when those decisions completely contradict your own advice.
Wow, that has to be really challenging in practice.
It's incredibly difficult. It requires you to completely separate your ego from your duties.
Yeah.
And then there's the mandate for compassion. The text explicitly states that providing emotional support carries the exact same weight as physical care. You are expected to be fully present.
Right, and confidentiality is absolute, isn't it?
Oh, totally absolute. A caregiver cannot share client details or health histories, even with unauthorized family members.
Let's just take a second on that, because I think that specific boundary is one many well-meaning people might accidentally cross.
Oh, happens all the time.
It's so easy to think, oh, it's the client's daughter asking. Of course I can show these medical updates. But the manual establishes a hard wall there.
It really does. Unless authorization is given, the information stays in the room.
And the way caregivers are trained to speak reflects these rigid boundaries, too. There's a whole section on communication do's and don'ts. You're instructed never to ask what's wrong with you, or tell a client, I know what's best for you.
Because that removes agency.
Right. Instead, you open the floor to them by asking, how are you feeling today?
Yeah, it removes that paternalistic tone from healthcare and places the power back into the hands of the person actually receiving the care.
There's a detail in the assessment guide that highlights this so beautifully, I think. During the practical exam, candidates are required to narrate their actions out loud.
The narration is huge.
Yeah, like, you must announce, I'm going to help you sit up now, Mr. Santos, and you must knock before entering a room. But the really fascinating part to me is that assessors require this narration, even if the candidate is just demonstrating on a plastic medical mannequin.
Assessors are meticulously watching for those small, habitual acts of dignity.
It paints the caregiver as almost like a respectful tour guide for someone's own body. You're narrating the journey.
That's a great way to put it.
But I do want to push back on one of the stricter rules here. The manual insists that a caregiver must gain verbal consent before touching the client or performing any procedure every single time.
Yes, every time.
Is it really necessary to ask for consent to adjust a pillow if you just adjusted that exact same pillow 5 minutes ago?
Well, see, what's fascinating here is that it goes much deeper than just polite repetition. Asking for verbal consent every single time prevents the caregiver from slipping into autopilot.
Oh, I see.
Yet when someone performs the same physical tasks day in and day out, the human brain tries to be efficient.
Right. It wants to take shortcuts.
Exactly. It's dangerously easy to start viewing the client as an object, like a piece of furniture that needs to be rearranged, rather than a person who needs assistance. Forcing that verbal boundary ensures the interaction remains consensual. It proves to the assessor and to the client that you still see the human being in front of you.
You still see the human being. Man, that is a powerful mechanism for empathy.
It really is.
So we talk about respecting a person's visible boundaries, but the manual is equally strict about invisible ones.
The microscopic one.
Right, because when you take on the responsibility of someone's care, you are essentially becoming their immune system's first line of defense, which moves us from the ethical realm right into the biological one.
Infection control.
Yes.
The manual relies heavily on a concept known as the chain of infection. It's the biological pathway that diseases use to spread, and assessors will often ask candidates to outline it.
It operates through 6 links, right? Usually taught with that mnemonic.
Yeah, the mnemonic is, in reservoirs, portals exit, modes transfer, portals enter susceptibles.
Let's decode that for the listener, because understanding how pathogens travel completely changes how you view your environment.
It really does.
So the IN stands for the infectious agent, the bacteria or virus itself. And the reservoir is where that agent currently lives and multiplies. Right.
Correct. So a reservoir could be a puddle of standing water, soiled bed linens, or, very often, the caregiver's own hands.
Got it.
The next link is the portal of exit. Like, how does the pathogen leave the reservoir? That could be through a cough, a sneeze, or an open wound.
Then we have the mode of transmission, which is the vehicle. Maybe it travels on a caregiver's unwashed hands or through airborne droplets.
Exactly. And then it finds a portal of entry into the next person, perhaps a tiny cut on the skin or a mucous membrane.
And finally, it reaches the susceptible host, the person whose immune system just can't fight it off.
And the caregiver's entire biological mandate is to break that chain.
Break the chain.
Yeah, and the most vulnerable point in that entire sequence is the mode of transmission. The manual is totally unequivocal here. The single most effective intervention to break that specific link is proper hand washing.
Right, and the mechanics of standard caregiver hand washing are incredibly precise. You turn on the warm water, you wet your hands and wrists, but the manual mandates that you must keep your hands lower than your elbows at all times.
The physics of that rule are vital. If you elevate your hands, the contaminated water runs down your forearms.
Oh, gross.
Yeah, so when you lower your hands to turn off the sink, that now contaminated water flows right back down onto your freshly cleaned fingers.
See, that is a fascinating contrast to what we see on television. I mean, if you watch any medical drama, the surgeons scrub in and then hold their hands way up by their shoulders as they walk into the operating room. Why the opposite approach here?
Well, context changes the protocol entirely. Surgical scrubbing is a highly specialized procedure where the surgeon scrubs their entire forearm up past the elbow and enters a completely sterile environment to don sterile gowns.
Oh, so they're totally sterile.
Right. Caregivers, however, are operating under what the manual terms standard precautions. They're working in homes or standard clinical rooms with exposed forearms.
Okay, that makes sense.
By keeping the hands lower than the elbows, the caregiver uses gravity to pull the pathogens down the drain, away from their body, and away from their uniform.
Using gravity as an infection control tool. I love that. And once the hands are wet, you move to the 20-second rule. You must apply friction for at least 20 seconds, interlacing the fingers, rotational thumb rubbing, cleaning the nail beds.
Rushing that phase is an automatic deduction.
And another meticulous detail here. When you finish rinsing, you are strictly forbidden from shaking the water off your hands.
Right, because shaking the hands aerosolizes the water droplets.
Oh, wow.
It turns any remaining microscopic particles into airborne projectiles that can just land right on your uniform or nearby clean surfaces. You have to pat them dry with a single-use towel.
And the assessors also enforce a concept called the clean to dirty principle in everything the caregiver does, right?
Yes, constantly.
You must always work from the cleanest area to the dirtiest area. If you touch a contaminated surface and then reach for clean medical supplies, the exam is over. You've compromised the safe zone.
You're constantly managing this invisible geography of bacteria in the room.
So we've secured the invisible environment, but the most immediate threat to a caregiver actually isn't microscopic. It's structural.
Oh, absolutely.
If a caregiver doesn't understand how to properly move a client, their career could end in a single afternoon from a ruptured disc.
Body mechanics. It's the leading cause of career-ending injuries in the medical field.
The manual outlines these laws of safe lifting because the caregiver's body is their primary tool and it has to be calibrated. You establish a wide base of support, keeping your feet shoulder-width apart. You bend at the knees, engaging the large muscles of the legs rather than the lower back.
And you keep the heavy load close to your center of gravity.
But the golden rule, the one that prevents catastrophic spinal trauma, is pivot, don't twist.
Pivot, don't twist, exactly.
I like to think of this almost like the physics of martial arts. If you watch a judoka throw an opponent, they almost never plant their feet and twist their spine. They move their feet to change their center of gravity.
That's a really great analogy.
If you plant your feet and twist your lower back while holding the dead weight of another human being, you're creating this lever that forces your smallest spinal muscles to absorb massive amounts of torque. You have to step and turn your entire body to change direction.
That is a perfect visualization. Twisting just throws the spine completely out of alignment and shifts the mechanical burden onto tissues that were never ever designed to bear it.
The manual applies these physics to very specific scenarios too, like wheelchair transfers.
Right.
When moving a client from a bed to a wheelchair, the protocol dictates placing the chair at a 45-degree angle, but interestingly, it insists the wheelchair must be placed on the client's stronger side.
Yes.
I found myself questioning this, like if a client has weakness on their left side, shouldn't the caregiver place the chair on the weak side to offer the most support?
Well, if we connect this to the bigger picture, that core philosophy of preserving independence, the reasoning becomes really clear.
Okay.
Placing the chair on the strong side allows the client to actively participate in the transfer. They can reach out with their capable arm to grasp the armrest. They can bear weight on their strong leg to help execute the pivot.
Oh, I see.
Yeah. It empowers them to use the muscles they still control while the caregiver safely manages the weak side.
It's about empowering them to do what they still can rather than just rendering them completely helpless.
Exactly. And for clients who cannot participate at all, such as those with suspected spinal injuries, the manual details the log rolling procedure.
That requires 2 caregivers, doesn't it?
Yes, 2 caregivers moving in total synchronization. The client is rolled as one single rigid unit on a count of 3, ensuring absolutely no twisting of their spine.
Okay, so we've covered the macro movements. Now let's explore how caregivers apply this meticulous attention to detail to the more intimate rituals of life.
The daily activities.
Right. The manual dedicates significant space to ADL's activities of daily living, and the depth of the medical knowledge required for just a simple bed bath is remarkable.
It really is.
Here's where it gets really interesting for me. The manual instructs caregivers to wash a client's extremities from distal to proximal, meaning you start at the ankle and wash upward toward the thigh. You start at the wrist and wash upward toward the armpit. Why specifically in that direction?
Because every protocol in this manual is rooted in human physiology. Washing from distal, which means furthest from the heart to proximal closest to the heart, actively promotes venous blood return.
Fascinating.
The veins in our arms and legs contain these tiny valves that help push deoxygenated blood back up to the heart. When a caregiver applies pressure and friction in that specific upward direction, They are manually assisting the client's circulatory system.
So it's far more than just surface hygiene. Every stroke of the washcloth is a calculated medical intervention. That completely transforms how you view the act of bathing someone. And this level of calculation extends to dressing, too. For a client who suffered a stroke and has paralysis on one side, caregivers memorize the acronyms DAW and UAW.
Right. DAW dictates that you dress the affected, or weak, side first. UAW means you undress the unaffected, or strong, side first.
So when putting on a shirt, you carefully slide it over the paralyzed arm first to avoid awkward stretching.
Right.
When removing it, you pull the strong arm out first so the fabric can easily slide off the weak arm. It minimizes joint stress entirely.
It's all about reducing unnecessary friction in their daily routine.
Now, when it comes to medication, the boundaries are intensely strict. Caregivers follow the 5 rights: right client, right medication, right dose, right time, right route.
The 5 rights, yes.
But the manual clarifies a critical limitation regarding a caregiver's scope of practice. And ISSers test this relentlessly. A caregiver is only permitted to assist with pre-poured medications.
The legal and ethical wall here is absolute. Caregivers must never prescribe, they must never calculate chemical dosages, and they must never administer intravenous injections.
Even in an emergency.
Even then. Stepping outside that specific scope of practice, even if you genuinely think you're helping the client, is an automatic failure on the exam and a major legal liability in the real world.
You really have to know exactly where your medical authority ends.
You do.
The manual also contains highly specialized care protocols that deal with life and death scenarios. For infants, the procedures surrounding the prevention of sudden infant death syndrome are incredibly rigid.
As they should be.
Caregivers are taught that an infant must always be placed to sleep in the supine position flat on their back. The mattress must be entirely firm and the crib must be completely bare. No loose blankets, no pillows, no stuffed animals.
The biological mechanism behind this is vital to understand. An infant's airway is incredibly soft, much like a flexible straw. If they're placed on their stomach, the weight of their own head can compress the jaw and actually pinch that airway shut.
Oh, that's terrifying.
Furthermore, loose blankets or toys create small pockets around the baby's face. When they exhale carbon dioxide, it pools in those pockets, and they end up rebreathing their own exhaust rather than pulling in fresh oxygen.
A bare crib is the only safe crib.
Exactly.
And what happens when a calm routine shatters into an emergency? The first aid section leaves absolutely no room for hesitation.
One.
For CPR, regardless of whether the client is an adult, a child, or an infant, a single rescuer must adhere strictly to a ratio of 30 chest compressions to 2 rescue breaths. The depth of the compression changes based on the size of the person, but that 30-to-2 ratio is mathematically locked. Why that specific number?
It all comes down to blood pressure. When a heart stops, the blood pressure drops to 0.
Right.
Chest compressions act as an artificial pump. It takes multiple consecutive compressions just to build up enough pressure in the vascular system to push blood up to the brain.
So if you stop
too frequently to give breaths, that pressure plummets right back to 0, and the brain starves. 30 compressions provide the optimal balance of maintaining cerebral blood pressure while still intermittently supplying fresh oxygen to the lungs.
the mechanics of survival. We see this exact clinical logic applied to burn management as well, don't we?
Yes, we do.
If a client is burned, the protocol demands cooling the tissue immediately under cold running water for 10 to 15 minutes. And the text issues a really harsh warning against old folk remedies. Absolutely no ice, no butter, and no oil.
Applying butter or oil to a burn is incredibly destructive. Those substances act as insulators. They trap the thermal energy inside the tissue, causing the burn to literally cook deeper into the muscle.
That's horrifying. And ice.
Ice is equally dangerous because it causes rapid vasoconstriction. It clamps the blood vessels shut, completely cutting off the blood supply to tissue that is already traumatized and desperately needs oxygen to survive. Cold running water safely draws the heat away without compromising circulation.
Man, let's take a breath here. We have mapped out a massive amount of territory today.
We really have.
We started with the psychological weight of asking for consent every single time. We examined how gravity and friction break the chain of infection. We discussed the martial arts physics of safely pivoting a human being. And we explored the deeply physiological reasons behind everything from bed baths to CPR.
And we deliberately took our time getting through it, which is exactly how this knowledge is meant to be applied.
It is, and I want to speak directly to you, the listener, as we wrap up here. Whether you are actively studying to pass this exact TESDA assessment, or you're preparing to care for an aging parent at home, or you just want to be a more capable member of your community,
Mm.
these protocols aren't just sterile bullet points to be memorized.
No, they're not.
They are the tangible tools we use for preserving human dignity.
This raises an important question, actually. That concept of dignity brings up a profound paradox in the very last section of the manual. Care documentation.
The clinical paperwork.
Yes. The manual insists that caregivers use objective entries only. A caregiver is legally required to document only what they can see, hear, smell, or measure.
Right.
The manual gives a specific example. You are taught to write, "Client consumed 50% of served lunch." You are strictly forbidden from writing, "Client had a poor appetite today because she was sad."
Because sadness is a subjective interpretation. You can't quantify it like a heart rate.
Exactly. It maintains the legal integrity of the medical chart. But consider what happens when we apply this over the course of years.
Okay.
The clinical chart becomes the permanent legal record of a person's final years or their long recovery. By stripping away all the subjective emotions, the grief, the sadness, or the joy, in order to maintain clinical perfection, do we inadvertently erase the actual human experience from the official record of their life?
Wow. That is a heavy realization.
Like a profound tension.
You're required to be deeply, actively empathetic while you're in the room holding their hand, but you must be completely clinical and unfeeling when you put the pen to the paper.
How do we balance those cold, hard facts with the deep compassion that caregiving demands every single day? It really leaves you wondering how much of a patient's true story is lost in the margins of those charts.
That is definitely something to ponder. Well, we honored the manual's advice today. We took a breath, we slowed down, and we didn't rush the steps, because when you stop racing against the clock and abandon the mentality of just surviving the checklist, you finally have the bandwidth to see the human being sitting right in front of you. Take care of yourselves and take care of each other.